Hello, we are going to talk about current treatment of epilepsies. Seizures and epilepsies are divided into focal, generalized, and unknown. The epilepsies are also subdivided according to the etiologies, including structural, genetic, infectious, metabolic, immune, and unknown. For the structural etiologies, MRI is the most important in vivo modality to diagnose lesions related to epilepsies. People with epilepsy have a brain disorder with localized or diffuse dysfunctional neuronal networks that provoke seizures and other comorbidities. Determining the cause of seizures is crucial to many of the management steps needed to improve lives of people with epilepsy. So we are talking about a situation where we have recurrent seizures that have diverse causes, numerous causes, different types of seizures, different comorbidities. So we are not talking about a single disease. And there is no anti-epileptogenic pharmacological treatment. The drugs are all anti-seizures, so they are only symptomatic. The concepts for treatment in epilepsies include starting a medication with monotherapy that will have minimal side effects. The treatment is based on clinical responses, and we should treat up to the seizure control or toxicity. And the adherence to treatment is a very important issue in epilepsy. If there is a failure to control seizures or too much toxicity, we should replace a medication with a second one, and following that, a third or polytherapy. Therefore, the treatment for epilepsy should be individualized. There is no similar response in two different persons, even though they may have the same type of epilepsy. And also we have lots of medications, especially over the last 10, 15 years. And we need to choose which one we're going to give to a given patient. So in relation to efficacy in focal epilepsies, for example, there is no clear superiority of one anti-seizure medication over the other. And one of the biggest advantage of the newer anti-seizure medications is best pharmacokinetic and drug-drug interaction profile. So the variables that interfere with the choice of anti-seizure medications are the medication itself that will be targeted according to types of seizures in epilepsy syndrome in many circumstances, the profile of adverse events, and other issues. But also the patient's characteristics, including sex, age, comorbidity, and others, and cost and availability of the medication. In many times, we try to avoid certain medication based on comorbidities of the patients. For example, if the patients have depression, we will choose medications that will interfere at least in this situation. The same for the other comorbidities as illustrated here. There are some medications, for example, the one here, which is ethosuximide, that will act only in absence seizure, a specific type of generalized seizure. But overall, the medications, they will act in a given type of seizures, independent which type of these medications. And we have the medications that are so-called narrow spectrum and the broad spectrum agents, as illustrated here. So depending on this, we will choose a given medication also according to the patient profile. The factors that are of particular importance, especially when we use polytherapy, more than one medication, is to take into account not only the safety and the tolerability, but also how these medications interact with each other and with other medications that the patient may be taking on. Also, it's important to take into account the mechanisms of actions of anti-seizure medications. Although many of those mechanisms are still unknown, we know major mechanisms of these medications. And for example, if we take a group of medications that act uh, mostly on the sodium channels, blocking or interfering with the modulation of the activity of sodium channels, it's not wise, for example, to give two medications that have the similar basic mechanism, because we are going to give two of the same type of actions. So it's best to choose different type of actions when we are combining the medication. Also, if one medication fails, it's wise to try to choose another one with a different medications. One of the most important things in treating epilepsies is the metabolism of these drugs. For example, the older medications, including this one listed here, phenytoin, carbamazepine, phenobarbital, and primidone, for example, are very strong inducers of the liver enzymes, and therefore they will affect the other medication they are taking, reducing the levels of these other medications. And also, they may be related to more side effects. At least 70% of people with epilepsy will be well controlled of their seizures with appropriate medication. However, there is a huge gap in the treatment. It is estimated that um, most people with epilepsy lives in underdeveloped country, and the gap include lack of access to these medications because they will not have this medication available. But also, even in um, high income countries or mid income countries, uh, there is a large population of patients who are not adherent to the treatment or decline treatment for many reasons. They fear the side effects of the medication. They don't want to take medication every day. And this is a very important problem, because non-adherent patients will have seizures that are not well controlled. Also, it's estimated that a poor adherence is associated with a much higher increase risk of unexpected death in epilepsy, which is called SUDEP, or other complications like burning, accidents, and other problems related to seizure. When a patient does not respond to at least two anti-seizure medications in adequate dosage and with a good adherence to the treatment, we call these patients having pharmacoresistant or refractory epilepsy. Those patients should be referred for a surgical evaluation, and this should be offered in all patients who are drug resistant. Does epilepsy care include defining the seizures with proper diagnosis, and try to find as much as possible the cause of the epilepsies, introduce the treatment, and in those who have medical intractability, we should consider surgical treatment. Surgery is more effective than continuing medical therapy in those who failed two or more anti-seizure medications. And this has been demonstrated in more than one study, showing the clear superiority of the surgical treatment. Understanding surgical outcomes of different surgery locations, pathology, non-lesional epilepsy, and incomplete resection will assist a pre-surgical counseling of those patients. Definition of the epileptogenic zone is reached with the integration of seizure semiology, EEG, neuropsychological evaluation, and multimodal imaging. The yield of an epilepsy MRI is directly related to the hardware quality and sequence, but also knowledge about the epileptogenic location, which is related to the experience of the examiner. There are recommendations of minimal standards for using MRI in patients with epilepsy that include 3D sequences with isotropic voxels of 1 millimeter or less with high quality structural images. With that, we can define lesions in most of the patients, and the best surgical outcome is related to the presence of a lesion on MRI and complete resection of this lesion. So the candidates for epilepsy surgery are patients who have persistent seizures despite adequate pharmacological treatment, and this will impair the quality of life of these patients, including increased risk of death in these patients. The pre-surgical evaluation is a multimodal task. So several professionals will take different steps on this evaluation. This will include history, physical exam, EEG, imaging, pre-surgical testings that include neuropsychological evaluation in a context of a comprehensive patient care that usually discussed during a multi-professional conference. So neuropsychological evaluation is done to evaluate the risks of the cognitive and other issues, and also how the patient is in terms of IQ, language, and memory, and so on. The epileptologist will present the patient in the conference. Video EEG are reviewed. That includes semiology, the localization of the EEG changes, and the other investigations are discussed. So what we need is to have convergence data on these investigations so that we can propose a surgery that can be resective, taking out a lesion, which is called a lesionectomy, or larger area of the cortex that may go as localized corticectomy or an entire or part of a lobe, such as temporal lobe resections. Sometimes resective surgeries cannot be done, and therefore we will have disconnective or palliative surgery that include functional hemispherectomy and also corpus callosectomy, which will avoid, for example, seizures that are very fast, generalized, and cause people to drop or falls, which is called drop attack seizures. And this can be very important for ameliorate the severity of seizures, but those procedures will not render patients seizure-free. So in conclusion, up to 70% of people with epilepsy can be seizure-free with anti-seizure medication. Patients with medically intractable epilepsies are surgical candidates, and all patients with epilepsy should undergo an epilepsy protocol MRI. And many modern epilepsy surgery options exist, including resection, disconnection, and palliative procedures that should be considered in all patients with pharmacoresistant seizures. Thank you very much.